Hi, and welcome to the Addressing Nutrition and Food Access and Medicaid webinar. We're excited for the group here. We have hundreds of people on the webinar, and the session will also be available as a recording. From a housekeeping perspective, there's a chance to ask question and answers in your web dashboard, and we'll address those in a question and answer at the end, and people may incorporate some of those into comments along the way. Today we have a collection of panelists and are breaking it into two parts. One is introducing the topic and the white paper that has been released and is available to people from a structural perspective, and Katie Garfield will be leading that section. And then we have panelists who are going to be talking about the experience of application of this in the community from the ground up, and also the policy implications. And Lauren and Emma will be focusing on those components. And all of this wouldn't be possible without the Food Trust, and Julia is representing the Food Trust this morning, and we really appreciate the support to make this happen and the drive to make it happen. I'm John Houghton. I am the chair of the Quality and Research Committee at the Population Health Alliance, and we've been working in partnership with all of us of putting this paper together. Briefly, the Population Health Alliance is the industry's multi-stakeholder professional trade association that focuses on population health management. We have membership from health systems to health plans to employers, academia, biopharma, and tech companies, and pull people together across the community interested in different parts of making care work better, from public health to clinical care to policy and data and information and workflow that move it all together. If you look on the screen right now, there are two QR codes. The top one is for a webinar on Thursday, the 27th, the state of population health, sort of like the state of the nation, that is a complimentary. And then there's a link for our innovation caucus in April in Washington, D.C. I'm going to turn it over now to Katie, and we will go forward, and really looking forward to a wonderful session here. Thanks everybody, and thanks to the attendees. We're really excited about this.
Welcome to everyone, and good morning or good afternoon, depending on what time zone you're in. My name is Julia Koprak. I'm an associate director of the Food Trust. We're a nonprofit organization, and we believe that everyone deserves access to affordable and nutritious food. We both conduct programming, and we work on policy efforts around a lot of different food access programs, but those include programs like produce prescriptions and heart health focused nutrition education, and partnerships with retailers, a range of retailers from farmers markets to healthy corner stores to large supermarkets. So with many of these types of projects and reports, it's been many years in the making, but really, we wanted to create this resource. We were seeing so many examples, including many of you who are with us today. I know we have, I think, over 400 attendees joining us live right now. But so many examples of whether it's community-based organizations and healthcare systems working together on nutrition efforts. That might be food pharmacies, produce prescription programs, medically tailored meals. And as usual, folks are thinking about two things. One, how do we fund these programs? And also, how do we build it into existing programs like Medicaid? And we hope that this report and this presentation today provides a tool and an opportunity to connect and learn more about these opportunities out there. So I want to share a couple of quick thank yous. One is to the Robert Wood Johnson Foundation, who funded this project through the Food Trust Center for Healthy Food Access. And I want to thank all of the contributors and interviewees that contributed to the report and the presenters today, and notably Brent Ling, who commenced this project when he was formerly at Population Health Alliance. And I do think that this report is timely for two reasons. One, I learned this week that USDA has appointed its first ever director of nutrition security, and that's Dr. Sarah Bleich. And it's just notable to see that, increased focus on nutrition security in addition to food insecurity and anti-hunger efforts. And also, well before we, as we started thinking about this report, we had no idea that we'd be facing a global health crisis, and one in which people experiencing diet-related illnesses would have significantly worse outcomes due to COVID-19. So my hope is that coming out of this pandemic, there will be, renewed and increased efforts that are so many of which are already underway to focus on preventative health measures. I will hand it over to our lead author, Katie Garfield, and who will lead us into a presentation. Thank you.
Excellent. Thank you so much, John and Julia, for that introduction to this important work. As Julia mentioned, my name is Katie Garfield, and I'm a clinical instructor at the Center for Health Law and Policy Innovation of Harvard Law School, which I'll refer to as CHLPI throughout the rest of this session, since we have sort of a lengthy name. And our center's mission is to advocate for legal, regulatory, and policy reforms in health and food systems, with a focus on the health, public health, and food needs of systemically marginalized individuals. I am thrilled to have had the opportunity to collaborate with the Food Trust and the Population Health Alliance on this new report, as the report really brings together all of the threads of that mission by examining the role that Medicaid can play in addressing nutrition and food access. My role on the webinar today is going to be to provide a brief presentation and then to facilitate a panel discussion on the core themes from the report. The report is broken into two parts, with the first part really focused on strategies for supporting these interventions, and then the second part narrowing in on considerations for implementation. In just a moment, I'll take us through that first section, highlighting the pathways that currently exist to address nutrition and food access in Medicaid. Then we'll shift to the panel discussion, in which we'll hear from experts on the ground about the challenges and considerations that they've grappled with in implementation. But before we get there, let's start with a basic reminder of the landscape that we're operating in, beginning with the question of why should healthcare be thinking about nutrition at all? Access to affordable, healthy food is fundamental to health and well-being. Without such access, individuals face greater risk of diet-related disease, increased healthcare costs, and death. Let's put this in perspective. Consider the following. Diet quality is the #1 risk factor for death in the United States. That surpasses even tobacco use. And access to healthy foods play a critical role in determining health outcomes and costs. Food insecurity, or lack of consistent access to enough food for an active, healthy life, is associated with an increased risk of a range of serious chronic illnesses, such as hypertension, stroke, cancer, and diabetes. As a result, researchers estimate that food insecurity results in $52.8 billion in excess healthcare costs each year. These trends have serious implications, not only for the US healthcare quality and costs, but also for efforts to advance equity in US healthcare and food systems. Like so many issues, trends in food insecurity and diet-related disease have been impacted by systemic discrimination, resulting in a disproportionate impact on individuals who are Black, Indigenous, or people of color. Given these connections between food, health, and equity, payers and policymakers across the US healthcare system are now exploring and investing in strategies to respond to these trends. These efforts have particular urgency in the Medicaid program, where low incomes and structural barriers can make it particularly difficult to access healthy foods, even with the support of broader food access programs like SNAP. So again, to set a bit of a baseline, this is probably review for many of people on the call, but let's just remind ourselves, so what is Medicaid and how does it operate? Medicaid is the United States' safety net health insurance program, serving more than 80 million people across the country. Medicaid operates as a state-federal partnership. The federal government sets baseline rules for the Medicaid program, and then each individual state administers its own program within this broader framework. This is typically done through a Medicaid state plan, and in some cases, the use of waivers to fill in important details around things like benefits and eligibility. And we'll talk more about state plans and waivers as we go forward. As part of this process, each state must also determine how to pay for services. Historically, state Medicaid agencies used a fee-for-service approach, in which they paid hospitals, physicians, and other healthcare providers directly for providing services. Over time, though, many states have moved to a managed care model in which states contract with private health plans known as managed care plans to administer and pay for care. Given the increasing recognition of the connections, again, between food, health, and equity, state Medicaid agencies and Medicaid managed care plans are increasingly investing in a spectrum of food and nutrition related services. And those services are outlined on this slide here, broken into some broad buckets. Traditionally, the services have included things like nutrition education, and in some cases, screening for food insecurity and referral to social service programs. But increasingly, we've also seen the proliferation of more direct approaches, such as food assistance models in which plans and payers may pay for healthy, medically appropriate foods, or even in some cases, invest in improving food access in the communities in which they operate. But how are states and plans supporting the provision of these services? Over the next few slides, I'll give a brief overview of 4 pathways currently in use to pay for nutrition and food access interventions in the Medicaid program. We'll start with grants and pilot funding, then move to state plan coverage, managed care, and Medicaid waivers, each of which is taken in more detail in the report. First, let's take a look at 2 of our more limited options, state plan coverage and public or private grants and pilot programs. As I mentioned earlier, the state plan is a document in which each state takes the broad federal framework and fills in key details to design its Medicaid program. Federal laws and regulations establish, for example, a series of mandatory benefits which states must cover and optional benefits which states may cover. States then use their state plan, states then fill in these details in their state plan. In some cases, states can use the state plan to cover some nutrition-related services by covering them under existing benefit categories. But I will note that this approach currently has its limitations. Historically, CMS has allowed states to cover some nutrition education and screening and referral efforts under existing benefit categories. But up to this point, CMS really has not explicitly allowed coverage of the direct provision of food, except in a couple narrow circumstances. Of course, federal policymakers could make policy changes to address this, either to interpret existing categories to include a broader range of nutrition interventions or by adding new categories. But until they do so, states and plans will need to use alternative approaches to pay for broader food assistance models. One common approach is to use grants or pilots to pay for nutrition services for Medicaid recipients. However, this approach too has its limitations. While pilots and grants are extremely flexible in what they're able to fund, as they may come from the state, the federal government, or philanthropy, and therefore have a range of goals and flexibilities, they may be time limited. And so they need to be paired with more sustainable strategies, such as funding via managed care or waivers, which we'll turn to next. As a quick reminder, managed care is the system in which state Medicaid agencies contract with private plans to deliver some portion of their Medicaid benefits. At least 40 states across the country currently use a managed care approach for some portion of their Medicaid program. Managed care plans must generally cover all of the services covered in the state's Medicaid state plan or some designated subset of those services. However, federal regulations provide several pathways that allow managed care plans to deliver extra services that go beyond the scope of the state plan. Those pathways are briefly outlined on this slide. They include flexibilities such as in lieu of services, value-added services, and activities that improve healthcare quality. As you can see from the slide, all of these pathways are in many ways fairly similar. However, there are a couple of key distinctions with big impact. For example, in lieu of services are in some ways the most restrictive option, as they must be approved by the state as a cost-effective substitute for an existing covered service. However, in lieu of services also has a number of added benefits that make it a particularly appealing option for plans. In particular, the cost of in lieu of services may be factored into the capitation payments that plans receive from the state. In contrast, the bar for, say, value-added services is lower, but plans receive no such payment from the state from the state for these services. Also, it's important to note that many states use managed care contracting as an additional way to potentially start thinking about social determinants of health and health-related social needs, such as food insecurity. In fact, many states use managed care contracting to require managed care plans to screen their members for social needs, provide referrals, and even in some cases engage in value-based payment models, which may include a focus on some of these issues. And then finally, just to round out our quick overview of potential strategies, we have Medicaid waivers. Waivers allow states to implement innovative Medicaid policies, such as paying for a wider range of nutrition interventions, but these are things that they may not otherwise have been able to do under federal guidelines. So to enact a waiver, the state must submit an application to CMS and receive approval. And there are a range of different types of waivers that states have used to cover non-traditional services. 3 such options are outlined on this slide. First, you see Section 1915C waivers. These waivers allow states to provide home and community-based services to individuals who would otherwise need an institutional level of care, such as a nursing home. CMS has historically allowed coverage of home-delivered meals under this waiver option. Next, we have Section 1915B3 waivers. These waivers allow states to use savings from its managed care program to provide additional services not covered under the state plan. And then finally, the category that many of you may be most familiar with, we have Section 1115 waivers. These waivers are the most flexible category of our waiver categories. These waivers allow states to launch demonstration projects that are likely to assist in promoting the objectives of the Medicaid program. And so states have used 1115 waivers to achieve a wide variety of goals. And a number of states, including states like Massachusetts, Oregon, and North Carolina, have used Section 1115 waivers to provide funding and support for nutrition interventions for Medicaid enrollees. And I'll just note that we will hear more about that particular type of waiver as we go to our panel discussion. So with those strategies in mind, I now want to turn to our panel. We realize that speaking about these policy pathways from pilots to waivers to managed care in the abstract really provides an incomplete picture of what it means to integrate nutrition into Medicaid on the ground. So all across the country, community-based organizations, payers, and policymakers are doing the hard work of putting that policy into practice. And as they've worked to implement the strategies we've described here, they're learning really valuable lessons that can and should really be guiding implementation in other states. So we're going to dedicate the second half of this session, and as you'll see, the second half of the report, to those types of critical considerations. And so we'd like to do that here by asking implementers from 3 states in particular to share their experience. First, from California, we'll be hearing from Dr. Emma Steinberg, a pediatrician and certified chef. Dr. Steinberg teaches culturally informed culinary medicine to medical trainees, patients, and staff. For the last 6 years, she has also worked with Bay Area community members, elected officials, schools, and healthcare providers to advise on and implement programs to reduce food insecurity and improve health equity. Next, from Washington, D.C., we have Lauren Schwader-Beal. Lauren is the executive director and co-founder of DC Greens, a nonprofit that works to advance food justice and health equity in our nation's capital. DC Greens' produce prescription program is a national leader in the efforts to integrate healthy food access into the healthcare system, with particular attention to Medicaid populations. And then third, we have Jonathan Weidman, the Vice President of Population Health at CARE Oregon, a coordinated care organization in the state of Oregon. Jonathan is a licensed professional counselor and certified clinical trauma professional. He has worked across the lifespan and with a variety of populations and is extremely passionate about spreading the knowledge of trauma-informed care to help improve our community response to the epidemic of trauma and reduce the transmission of adverse childhood experiences. So I'm going to put away the slides here. And I'm going to ask all of our panelists to turn on their video And to begin, I'd like to ask each of our panelists to give a brief introduction to the experience of working to integrate nutrition interventions into their Medicaid landscape, specifically focusing on the questions of what policy levers and services have you focused on, and are there any initial lessons you can share? So to kick things off, I'm going to ask Dr. Emma Steinberg to tell us about the experience in California.
Thank you so much, Katie. Can everyone hear me okay? Awesome. Hi, everyone. Thanks so much for being here. As Katie mentioned, I'm going to talk about California's recent experiences with covering medically supportive food and nutrition services via Medicaid. So California, as of January 1st of this year, has approved covering these services via Medicaid through the in lieu of services, or ILOS mechanism, as Katie mentioned earlier. The primary goals of this initiative for the whole state, beyond just covering medically supportive food and nutrition, was to address social and structural determinants of health, to improve racial and health equity, as well as improving quality outcomes and delivery systems through value-based initiatives. I should say that medically supportive food and nutrition services are just one of 14 buckets of services that are covered within California's ILOS. These other buckets include things like housing supports, transportation, and other chronic disease supports. As Katie mentioned in the intro, the ILOS mechanism is really designed to provide flexible wraparound services that are a substitute or intended to avoid other expensive covered services for Medicaid beneficiaries like ER visits, a hospital or skilled nursing facility admission, or even a prolonged admission. I would be remiss if I didn't mention that this funding comes separately, so it does not impact any of the other Medicaid programs that are currently being administered through California's Medicaid program. I will say, though, that unlike other programs within California's Medicaid, for this particular set of services, health plans do have to opt in to provide these services to their beneficiaries, but it is structured as a 5-year pilot. In terms of the services that California is covering, it started out just intending to cover medically tailored meals, but as a coalition, we advocated for a broader spectrum of what we call medically supportive food and nutrition services, which you heard me mention before. That also includes things like medically tailored groceries, healthy food vouchers, and food pharmacies. It can also include behavioral, cooking, and/or nutrition education when paired with direct food assistance as well. And we felt really strongly about broadening this spectrum of covered services because we think that it will allow healthcare providers to better tailor each intervention or service to individual patient needs, which we hope will increase patient autonomy, flexibility, make these services more sustainable, and provide more opportunities to ensure that the food supports are culturally relevant. Finally, in terms of our key lessons learned and some of the best practices that we tried to employ along the way. First, as I mentioned, I'm part of a coalition. We built a really diverse, well-connected coalition of community-based organizations, representatives from the Department of Public Health, health plans, and other healthcare providers throughout the state. We also looked heavily to the precedent set by others in Massachusetts, North Carolina, and Oregon, as well as other successful programs that came through Medicaid waivers or ILOS, like the Diabetes Prevention Program. These really helped give us a proof of concept that this model can work on a large scale, which really helped strengthen our argument with DHCS, our Department of Healthcare Services within the state. And then finally, just to echo something that Julia mentioned at the beginning, and Katie also mentioned in her report, California, like many other states and places, is really motivated to make improvements in racial and health equity across the state. And while COVID slowed the timeline of implementation of these services and ILOS, the attention on racial disparities and improvements to our healthcare system and chronic disease management really were huge additional motivators for covering things like medically supportive food and nutrition services, housing supports, transportation, et cetera, through the ILOS mechanism. And I think one of the things that our coalition also was able to do was leverage the media, organized medicine, and partnerships with local and state government officials to show that this really is a tangible way that the state can address racial and health equity issues and help in the long term. So with that, I'll hand it back over to Katie.
Thank you, Emma. I think so many important lessons sort of coming out of what you framed out in California. If we're thinking about states learning from one another, I think that proof of concept point of sort of looking to other states, I'm very hopeful that many states are now going to look to California as a proof of concept, particularly on in lieu of services. It's definitely a pathway that we've historically seen more used around mental health services. And so it's so exciting to see it really being expanded out and starting to be used as a tool to address health-related social needs. I also just want to quickly underline that piece about coalition building as we think about this. I think, you know, in California, you all have done such a great job of making sure that you're bringing a lot of stakeholders to the table as you're thinking about how these programs ought to work. And I would say we've had sort of a similar experience in Massachusetts with our 1115 waiver and our flexible services program, where I work with a coalition there that does a very similar effort to really think about it from various angles and bring folks together to inform advocacy around these efforts. So great work, and I'm excited to hear more as we continue on the panel. And next, I want us to hear from Lauren, who can particularly give the experience from the viewpoint of a food access organization that's been working to partner with health plans and Medicaid in DC. So Lauren?
Yeah, great. And this is really exciting to be here. This resource is something that I wish had been in place when we'd gotten started. And, you know, I'm just sort of thrilled to be a part of the momentum that I think is growing around integrating access to healthy food as a component of healthcare delivery. So DC Greens is based in DC, is focused on DC as the city state that we are. And you know, we really started a produce prescription program. We're focused on a produce prescription program, and we started it really back in 2012 as a sort of an effort to try to integrate the farmers market landscape at that time with, you know, with some of the federally qualified health centers that were operating in the city, and, you know, really wanted to be able to increase access to healthy food for their patient populations, their Medicaid patient populations. Over time, you know, what we ended up doing was realizing that having the incentive of having healthy food be available through a clinical visit was actually increasing patient retention at the clinics. And it was something that the clinics had sort of marked as, you know, they were excited about sort of some of the biometric things that they were seeing, but what they were really seeing was that people were showing up more frequently. And what we ended up doing is, and I should say DC Greens is really, like the Food Trust, both a direct service and an advocacy organization. But what we started to do is realize, you know, this was right around when people started talking about value-based care. You know, I think the Affordable Care Act had just come out, and a lot of the Medicaid, the sort of local Medicaid, the MCOs were, you know, trying to think about how do you retain patients for all of the other types of services that we know are beneficial. And so we actually kind of ended up approaching AmeriHealth Caritas, which was the Medicaid provider in DC, and saying, look, we've got this sort of data from our initial look at this, you know, would you be interested in sort of coming along with us on this? And so I think the story that we have is really one of figuring it out as we go along. And, you know, I've had to get smart on, you know, healthcare policy. I have no background in this. It's an incredibly complicated field. And I think, you know, there've been a lot of lessons along the way, things that seem like they should be easy and straightforward, that in fact are incredibly complicated and require enormous amount of more time than you think, and enormous more amount of certified professionals than you think you should need for something. So we can get into that later in the panel. But as the program evolved, it became very clear from speaking to participants that they really, they love the farmers market landscape. They really wanted to have a brick and mortar option. That's something that was just open, not sort of a short window of time in the week. And so we really worked to build out the produce prescription program to be in collaboration with Giant Foods, which is has the only full service grocery store in Ward 8 of DC, which is an area of the city that is predominantly Black and multi-generation poverty, high rates of diet-related chronic illnesses. So we've now been running a produce prescription program together with Giant Food, and we now have all of the Medicaid providers involved with us on this program. We were also able to push the city to put funding behind produce prescriptions into the city budget, which initially was coming through the Department of Health. And what we realized in our sort of perpetual learning around this is that really wasn't the best site for it. And really it needed to move over to the Department of Healthcare Finance. And again, in my ignorance early on, we thought, Department of Health, but in fact, they're really dealing with more of the population health issues. And what we realized is if we really want to have this integrated into healthcare delivery, we need to make sure that we're partnering with the agency that's really in the weeds on healthcare delivery. So, lots more in the question and answer, but that's the snapshot of where we are.
Excellent. Thank you, Lauren. And I think you've brought up a lot of really important ideas that we'll talk about more throughout the Q&A, particularly some of these issues around thinking about data and evaluation, where we'll go next, but also some of these issues around things like infrastructure, as you were talking about, that need to engage certain professionals and new systems. We can also get into that, as that's certainly a common barrier that we've sort of heard across the spectrum of nutrition intervention programs. But before we jump into those next questions, I'd like us to hear from Jonathan Weidman, who is coming from Oregon, one of the states that is in many ways arguably one of the furthest along in this process, given the length of their 1115 waiver history and their CCOs. So Jonathan?
Yeah, thank you so much. And similar to Lauren, I'm so excited to be here, and I love to have this conversation. So anytime someone wants to talk, it's funny too, we do feel, I think in Oregon, we've had our 1115 in place since 2012. We're organized in these coordinated care organizations, CCOs, which gives us a lot of power in terms of coordination and, being able to work with our communities. I mean, that is the point of the CCO structure, is to be able to be the hub for all of those pieces: social health, behavioral health, physical health, So it's been a very interesting journey to figure out how to integrate those pieces all together, including, food insecurity being a major factor. And, being able to see from a really data perspective, from an evaluation perspective, how all of the components of a human's experience fits, like how does food insecurity ultimately impact someone's health outcomes on the physical health side, is just an example. And so, Oregon has a lot of experience in that. For our waiver, we have basically flexible services similar to a lot of other states, which is really broken down into what we call community-based investments, CBI, and then flex services, which is really more of kind of like that individual one-to-one service level component for social needs. And it's funny, similar to Lauren, I mean, I feel like we're a far way along, and we're learning and growing and changing all the time. And really realizing how imperative our partnerships are with our CBOs in our regions. It's just, we cannot do this work on our own, and they are doing, heroic work, especially during a pandemic. So how do we help support them and funnel those dollars appropriately to them to support the community, our members, et cetera? And we have been really thinking about a couple things. One is breaking it down into what we call food delivery programs. So building out robust food delivery programs with our CBO partners or with, national vendors like Mom's Meals, for example. Doing lots of pilot opportunities. We're just launching a Healthy Birth Initiative pilot, which is, partnering with our Healthy Birth Initiative programs along with a culturally specific chef in our neighborhoods who will provide culturally specific meals to BIPOC moms pre and postpartum. So we're excited to be able to try those things, and I think the waiver opportunity allows that flexibility to be able to test some of those hypotheses in terms of how that will impact overall health outcomes, especially for newborns is a good example. And then we also look at CSA support and Veggie RX, as Lauren was describing. Our Produce RX programs are pretty robust and spread throughout the regions. We find those so powerful for people, and I think similar to what Lauren was saying, we got to figure out how to access, where to access, who, where does it actually happen for people? Do they want a brick and mortar? Do they want something more mobile? Do they want it through their clinic? And ultimately, I think you got to do a little bit of all of that in order to help people have access. But we have certain hospital partners that are very excited about our Produce RX program. So, looking to expand that, I think, as well. We do have also what I call like food literacy programs. So just helping people understand nutrition, helping people understand where to access nutrition, what is nutrition. We're starting this new partnership with a teaching kitchen that really combines not only cooking classes and access to a food pantry there, but also, really specific nutritional support for them is a good example. And then I can talk more as we go through the panel about some sunsetted programs or things that we kind of realized didn't work so great and why. But that's kind of where we're focused right now.
Again, a lot of really great themes really coming out at the start there. I love your point about thinking broadly about what interventions work for which individuals. I do think that's been a trend in this space, is really sort of a growth and expansion of the spectrum of services that could be provided here. Everything ranging from very, very targeted, specific, intensive approaches like medically tailored meals, which we know can have such an incredible impact, especially for chronically ill individuals, and then to broader programs that may have a sort of treatment or prevention approach, like a produce prescription or medically tailored food package. So really exciting to hear that sort of a lot of that's getting wrapped into Care Oregon's thinking. I also, one of the things I wanted to bring out that I think is really interesting about Oregon's model too, is the way that they have sort of built in a bit of an upstream downstream approach, which I think is interesting as well. This idea of being able to target and providing sort of funding that is able to address both the individual health needs, but then also those community-based investments, which I think is really interesting because so often I think sometimes we hear sort of upstream and downstream being sort of in tension with each other, or perhaps in competition for dollars, and really recognizing that it's not an either or, but a both and, I think is really exciting in Oregon. But I'll stop because we should let us hear more from our panelists. So now I think what we're going to do is zoom in on a couple of key points that started to come out in those comments, but which I think are really common across the country in these efforts, and are points that we've raised up in the report. So one of the points that we heard several of you mention already is this idea of research and evaluation. So we know that research can play an important role in guiding state and health plan decision-making. So what role has evaluation played in your state or your organization's approach to nutrition services? In particular, what sort of metrics are you interested in evaluating? And have you faced any challenges in creating effective evaluation? So maybe since it came up a bit in your comments, Jonathan, I'll ask you to speak first.
Yeah, I'm happy to. Yeah, I would say more challenges than anything. And I think it's because you try to be really mindful and thoughtful of the service, the individual need, the infrastructure around you, and you try to make it as simple as possible. And what we know is really robust evaluation is not simple. So, we're always balancing this act of, okay, we want to do this program. We want to honestly, at the end of the day, get people the food that they need in order to feel healthy and be healthy. If we can do some evaluation in that process, great. If not, like, we're just going to believe what we already know to be true. So I think that's a big piece of it. The other thing is just the data is so disparate, in terms of referral data, for example. Oftentimes if we do, a big CBI grant and we just provide, as you were saying, this flexible amount of dollars to a community to do the work they need to do, we're not going to get a lot of data on the back end because it's not really individualized in that way, right? And then we can't tie it to health outcomes. And so, instead we're trying to do some of that work and then start to build out very specific programs. The Healthy Birth Initiative one is one that I think is a really great example of our opportunity to connect with multiple partners to gather data so that then we can put it all together on the back end. So I would say that one is a great example of one that we're going to be combining not only the referral data, the social needs data, the actual meal data and liking of that meal, but then also how did that impact a variety of metrics, including breastfeeding metrics for that one in particular, stress levels, behavioral health situation, depression, anxiety on the benefit of the mom. So we'll be tracking a lot of those metrics. So I'm excited for that piece of it too. The other part I would say most robustly we've had is our meal delivery, post-discharge meal delivery through Mom's Meals. And, again, that one's pretty great because you can connect it to a lot of pieces of data. What we're doing right now is really looking at the totality of that sample set because we've done it for long enough now that I think we have a large enough sample to start to make some, decisions around what does that really tell us. It's always difficult with the post-discharge kind of situation because you have a lot of regression to the mean and those kind of things that you got to kind of balance around. So for us, it is a balance. Like, we want to get good data because good data and evaluation helps us make the case. I think we're also really lucky that we live in a state that really sees the value already. So I'm not having to make that case all the time. And we want to do the right thing for people. So I do think it is a kind of a balance of that. But, we're going to be moving more and more towards true health outcomes now that we're getting some of that social health data. How does, nutrition affect people's chronic disease progression? How does it affect their hospital rates and their ED rates? How does it affect just their overall sense of well-being in their community? I think is also another a good metric.
That's fantastic. Oh, and I see Lauren jumping in. Go ahead.
I'm gonna jump in, but if you want to move us along, whatever.
Yep. No, go ahead.
Just a couple of quick things I want to say, which is, I think we realized early on, and I'm married to a doctor, and he was like, it takes a very long time to move biometrics on, for patients. And we initially had really been getting just the sort of biometrics from the sort of clinical visit rate from the clinics. And what we decided when we shifted over to this more robust grocery store based model was really that we wanted to have access to claims data. And that what we felt like we were hearing was, in order to actually have real policy change around this, we need to be able to show that there's cost savings. And so those cost savings are most likely, we believe and continue to believe, going to be found inside of the claims data. So, ER diversion, medication compliance, are people staying on the continuum of care and getting all of those other benefits more than just sort of only looking at the impact of the food itself. And so we, because we were so dedicated to having access to those claims data, that's really been incredibly complicated. And there's no MCO or nobody's going to give me access to claims data, nor should they. And we took a very long time before we actually identified a partner, which is Socially Determined, that is a for-profit company whose job it is to analyze claims data and sort of spit back learnings from that claims data. And, once we went into partnership with Socially Determined, it really allowed those data sharing agreements to get, hammered out and allowed for some of that flow. But we're still in the midst of a sort of evaluation around that, but really focused on claims data. The other thing that I will say that we also have done, interviews and have talked to the sort of clinicians themselves, and a lot of the qualitative data about, doctors saying, I finally have a way to help my patient follow my medical advice, and I feel so much better in my job because I know I can actually physically give this, diabetic, food insecure patient something to do. That I think is a really great data point that people don't look at enough, just sort of like the satisfaction of the doctors, and also the relationship. What we found was there was an improved sort of positive feelings about their healthcare provider from this as well. So I do think that there's some survey data that is important and interesting.
I just want to call out really quickly, Catherine Couch, one of our coalition members, threw a really awesome example of some data analysis that came out of a medically tailored meals pilot in California, which Julia highlighted also, but just want to sort of give credit to that. And then just second the piece on the importance of data sharing and coordination, because I think this is going to be so important for everybody to not reinvent the wheel and try not to duplicate efforts. And while the data sharing piece and some of those agreements, especially with HIPAA and EMRs and claims data, is going to be challenging, I think we will all benefit if we try to do a lot of coordination from the get-go in order to try to make that more seamless and easy.
Absolutely. And I think a lot of great messages coming out of this conversation, right? Some of the challenges associated with evaluation, but also the benefits of it. I also love some of the broader metrics that are being pulled into play here around patient experience and also healthcare provider experience. So, so really encouraging to hear about those efforts. Next, I want to move us on to the idea of community engagement. So one tricky thing that we're aware of and that we bring out in the report is the fact that barriers to food access can vary significantly from community to community. And so community needs may differ. And so seeking community input can be a critical step in setting up a successful program. I'd next like to hear a little bit about how your state or organizations have used in community engagement to shape the services that it's offering in these programs with Medicaid.
Can I jump in? Because I'm actually really excited about what California did.
Go for it.
And there was also a question in the chat about this, so I want to make sure I cover it. I think California did a really wonderful job with this and its ILOS process. They made it completely open with readable versions of the ILOS services written in plain English and provided a ton of guidance documents and materials in advance throughout multiple periods, throughout over a 1 year period, which allowed us to provide comments multiple times on multiple different aspects of the ILOS services. So definitions of services, rate guidance, billing, and coding. And as part of this, our coalition was able to reach out to tons of health plans, other community-based organizations to get their input and flag it for people who may not have known that this was available in public, and either sort of collate all of our comments together to submit in one sort of fell swoop, or encourage people to submit their own comments independently. And I think this was really great because it allowed us to make changes and help inform things before implementation. And I think the transparency and comment period over a relatively long period of time just really allowed for pretty excellent community engagement and opportunities for people to provide comment.
Yeah, and I would just, double down on that, Emma. I think it's that is the way, is open and broad and clear, and that because you find things you didn't know. You find these CBOs that are doing fantastic work that you didn't even know, and they're doing a really specific piece of work that is really amazing, and it gives them all access to those dollars and that resource. So I would say we've done it on a smaller scale within the Care Oregon footprint, but very similarly we we open up a variety of grants and CBI dollars annually, very broad. And you get some really amazing things from people that are doing fantastic work. And so, yeah, I would agree with that. I think the more open, broad, and clear you can be, the better to engage the community.
I would say, one thing, so DC Greens really works to center folks who are most impacted in all of our program design. And we've actually struggled a bit with our produce prescription program because of HIPAA and because of the fact that as a CBO, and in order to do some of this work, we've actually had to be kind of arm's length from the participants. And remember, a produce prescription program, we're sort of facilitating everyone's ability to actually have money in their pockets to be able to shop at the grocery store in their neighborhood. So, in a design like that, we are not, hand delivering anything to anyone. We've had some modifications in this year so that we actually are able to have direct contact with patients. We prior to that, they really had to opt in, and we would then take that opt in and have sort of one-on-one conversations in order to get some feedback around patient experience. But we're very excited in the coming year to be able to do some bigger focus groups, both about program design, but also really visioning the future. And I think, anybody who has been paying attention to this field, there's a report coming out from a group of researchers that the Aspen Institute brought together. And it's really very much focused on, having more patient-centered design in how we're even thinking about this set of issues. So very grateful to the Rockefeller Foundation for supporting some of that patient-centered focus group work that we're going to be doing in the coming year.
Absolutely, and I'll take this as a moment to quickly plug that report that is coming out next week, which is the Food as Medicine Research Action Plan. And I'll share a link in the chat for that very exciting and sort of 18-month effort to really think through the peer-reviewed literature related to food as medicine interventions and key gaps and recommendations moving forward. I know that we are coming up on our time, so I do want to just try and squeeze in a couple extra questions and get at some of the ones in the Q&A. Though I will note right now that we are planning to have some follow-up events. So if your questions don't get answered directly today, there are going to be opportunities to ask them in the future. So one of the questions that has come in is, how can hospitals and health systems work more effectively with CBOs to provide food prescriptions to patients with food-sensitive chronic conditions? Our experience has been that foods provided at food pantries are not always compatible with specific diets for conditions like diabetes, congestive heart failure, et cetera. And it can be challenging to know what foods are provided to which patients at scale. So does anybody want to talk a little bit about making sure that we're connecting patients to the foods that they need from a medical perspective? I think, go ahead.
Oh, I was just going to chime in really quick. I think it goes back to what I was saying earlier, which is kind of you need a variety of services, places, so that, because I'm, as a pop health person, I always think about like populations and subpopulations and specific needs of subpopulations, right? And so, I think this is a great example of one that you could build like a medically tailored meal program that's very specific to a subset of people, for example, or there's some really amazing CBOs that do different things out there, like culturally specific CBOs that will do dietary specific, food items in a culturally specific way. Because that's the other thing we run into a lot is we could connect them to, some sort of very wonderful medically tailored meal or something. And then they go, I don't want to eat that. Not only is it not going to help me, but it's not culturally specific for me. It's not the kinds of foods that I grew up in eating. And so kind of helping, I think, find those specific CBOs that can do that. And then really being prepared, at least as a health plan, us being prepared to really support them in that work, because it's a lot of infrastructure and it's a lot of cost to be able to do such a thing. So I think that's really important. And then, there was one other thing and I'm forgetting. I'll chime back in if I think about it. But I think getting a variety of resources is really important for that.
And I'll just quickly add to that before we move on to maybe our closing question. just to emphasize that there are so many programs that are really springing up across the country that have this specific idea in mind, the idea of trying to provide foods that do address sort of specific health needs. Again, we talked about some of them earlier, the idea of medically tailored meals, medically tailored food boxes, produce prescriptions, really, which are all meant to sort of build upon the existing safety net programs, right? I think that's also an important part of this conversation and something that's coming up in the Q&A. Sort of calling out SNAP and WIC as an incredibly important foundation. And I can comment that I know in some states that building in referrals and making sure that people are being connected to those systems is so important, and being able to connect to broader food access programs. But then there are many programs that are coming into play that sort of build on that foundation and say, okay, for individuals with these health conditions or these risk factors, we can provide an extra layer of support that's more tailored. So I just wanted to call that out in response. And I know that we are now really up against our time, so I'm going to do one final lightning round and just ask each of our panelists, as you look forward to the rest of 2022, what is the one new policy program or other potential change in this space that you're most excited about? So lightning round, who would like to go first?
I can jump in. So we obviously just started in California as of January. So I think implementation is definitely number one, but I would say sort of as a sub bullet to that is that there is a ton of conversations going on about billing and coding as a result and part of the implementation. And so I think shifting the conversation nationally and potentially making changes to get more accurate billing and coding will be really exciting.
Absolutely, Lauren.
I would say I'm really excited about the sort of national move to give SNAP a raise, because I think that that's sort of a baseline for all of the work. A lot of this comes down to poverty and making sure there's more money in people's pockets. So that's exciting. I think that these conversations are exciting, and the fact that we're starting to really feel a lot of momentum around food as medicine and a lot of collaboration and learning. And I would also say for us, moving out of that grants model and hopefully into a contract-based model is something that we're really hoping for and pushing on in this coming year.
Yeah, and I would just say ditto, all of that. I'm very excited about it too. And Oregon's going to really start doing in lieu of services more robustly. So I'm looking forward to looking at California and figuring out how we incorporate that into our flexible services. So super excited.
Well, that's a great note to end on, and I'm going to turn things over to Julia. And I just want to thank all of our panelists for all of your insights. As we said, one of the key themes in this report is learning from one another. And so we've tried to incorporate case studies throughout, but it's so much more helpful to even just hear you all today about your own experiences. And I'll let Julia close us out.
Sure, and I may put in a question for you, Katie, that there were so many excellent questions that came up, and possibly when we share the recording out, we might be able to address some of these frequently asked questions. I know we're just scratching the surface here. I think this was meant to be a conversation starter, and here are some examples of ways that these things are happening. But each of the fantastic questions that a lot of our audience raised could be a discussion in and of itself. So, I hope this is the start. Folks can expect to see an email coming from Harvard CHLPI with the recording and with an opportunity to take a survey and create some other opportunities to connect in the future. So please look out for that. And thank you, Katie, for an incredibly informative and thorough overview in a short period of time and an exploration of just some ways that these partnerships can work. So I encourage folks to read through the report that was shared in a link in the chat. And thanks everyone again so much for joining today. I wish you all good health and hope that a nourishing and delicious meal awaits you this weekend. Thanks again and take care.
Thank you. Bye-bye.